do all of it. It's because of the compensation mechanisms, right? Now, we're going to do it separately, but ultimately, when you're in clinical practice, you're pretty much going to flow between all of the structures, depending on what position the patient can get in, okay? What position the patient can get in.
Can you do it for this one? Because I had an operation.
Now, I should pay, you should pay me. It's all right, I'll come round.
That's why he jumped in.
לא, סטייט, שהוא מסתובב. תשאר. הכל טוב.
אנחנו מסתדרים.
Look, it's easier for me to just fucking do this.
Then you'll be in the back for them.
Don't worry, man, they get the best view. Yeah? It's all good. Don't worry about it, it's all right. Pay extra, yeah? Pay extra. Pay extra, pay extra.
You wish to.
Okay, so when we're working through the knee, we have to factor in hip and lumbar, SI. If they're in an acute position or acute pain, you may not want to get them supine, right? Because if they have acute lower back pain, supine and prone tends to be the positions that we don't want to get them in, because it can hyperextend or can cause them discomfort, right? Fibular head. Now, all right, fine, it's non-load bearing, but it does have a correlation to the ankle. So when I'm looking to mobilise the fibula, I tend, if you're going to manipulate it, you tend to shunt it this way, right? There are manipulations to theoretically shunt it back that way, but to be honest, I've never really used it. I don't know if you've ever used it, or as a chiro. Are there any other chiros here? Any other chiros? Just you? Right, I'm going to take the piss out of you for 2 days now. Exactly. But I will show you in a second the sort of sideline position. So what do I have to be wary about when I'm starting to work into this area, though? Because there's some significant neurovascular structures here, right? Yeah, there's a fucking big outer nerve, but also when people come into working onto the fibular head or to the knee, they'll sort of come in and grab it and sort of dragging it around. What sits behind the back of the knee?
Tibial line.
Well, you've got the popliteus. Popliteus artery nerve sits very much in the midline. And actually, it's a big mistake when people try and mobilise or manipulate. They get the soft tissue structures and they drag it all the way around, or they're sticking their hands behind and actually compressing the structure. And it can be really uncomfortable. So what I tend to do from here is I'll find sort of the tibial plateau. Okay, I find the tibial plateau. I come off it because I know that the fibular head is going to sit here. Okay, all I'm going to do is just push the soft tissue posteriorly. Yeah, and then I'm just going to bring it anteriorly. So all I'm doing is I'm using my body weight to lean forwards. Yeah, so we are just getting a gentle mobilisation through the structure. All I'm doing, contacting, rather than using my thumb or finger, which is really labour intensive, I'm just going to contact, lock it in, and then just lean my body forwards and backwards, just shearing that anterior posterior, like so. If he can't do that because of the knee or because of the hip, then I'll do it sideline. Okay? On to side. Notice I have to control the lower leg. Okay? Now, depending on what I want to do, whether I want to try and posteriorize it or anteriorize it, I'm going to have to adapt the position of the foot accordingly. Okay? So I'll do like a cross-handed technique. So all I'm going to do is I find where the fibular head is, and I'm going to just use my pisiform, this section here, just to lock in front of it. Okay, this is what I call a C curve. Yeah, and when we come into like the CT and stuff, I don't compromise my thumbs at all. So you don't see me doing techniques like this, because if you apply too much pressure, you end up compromising your thumb joints, right? Manual therapists love to sort of poke stuff. It's freaking uncomfortable for the patient and for you. So I tend to use a pisiform contact. Now I'm going to lock it in. You'll notice I still get up into a good strong stance, and I have like my contact position on the table. And all I'm going to do is I'm going to just bring the foot away. So I'm just going to rotate it. So if you look at we look at it from this position, I'm going to bring it slightly up, right? So I'm going to bring it slightly up. That's going to give me more ability to lock in. You see there? Yeah? Happy? You happy? Makes sense?
Yeah.
Right? So the bone comes up. This gives me a natural lock. This allows me in this position to start to shear it posteriorly. So I'm locking up, my position is strong, my arm is in this angle, and I am just leaning my body forwards. You're right, quite strong actually. And I'm just posteriorizing that, like so. If I wanted to anteriorize it, I just change the foot position by rotating the lower leg, and we start to bring it round. That will give us the ability to hook our pisiform behind it, and again start to shear it forwards, like so. Yeah? The key thing with this is we want to have a cross-arm technique. Control the lower leg to try and bring the bone slightly up, so we've got a ridge that we can lock our pisiform against. Okay? This takes pressure out of the knee, hip and lumbers. Just bear in mind in this position, guys, remember, we are into our hip, yeah, into our external, into our internal, into our flexion, extension, it's money, yeah, into all of this. Remember, because obviously, look, we've got to think about the knee, we've got to think about the hip. We're into our lumbers, yeah, so we're in our flexion, mobilization, we're in our side bending, like so, yeah, makes sense? We're in our foraminal gapping, because obviously issues here, we've got to compensate. We're in our SI. Tomorrow, weekend, lumbar manipulation, back down into our fibula, and then even come down into the lower extremity of the ankle and foot. So you can see we can start adding in mobilizations, manipulations, and it will start to work fluidly rather than being all blocky. So tomorrow what we'll do is start adding in how I would mobilize it, manipulate it and mobilize it, because I add articulation post-manipulation pretty much after everything I do. I feel it's a great way of just reinforcing the technique whilst you've had this temporary change in quality and quantity of movement, and I also think it helps to sort of reinforce some of the neurological effects of manipulation. Starts to, and we'll cover some of that thought process. All right. So let's look at the fibula head. If you want to, add in a little bit of lumbar and SI, and then we'll come down. Just look at the ankle, subtalar, a little bit of the bones of the foot, a bit of navicular, a bit of cuboid, a little bit of cuneiform, a little bit of this, a little bit of that, and then we'll move into some theory. Cool? Cool. Awesome.